Hello, everyone. My name's Joe Cuthbertson from the World Association of Disaster and Emergency Medicine, and this is the Pre-Hospital and Disaster Medicine Podcast 2. For today's podcast, we're looking at a new piece of research recently published by Canaan and Peter. They're the Outreach Director and Executive Director, respectively, of LFR International, both are EMTs and currently studying medicine over in the US. Their research is developing a lay first responder program in Chad, a 12-month follow-up evaluation of a rural pre-hospital emergency care program. Welcome to the podcast, Canaan and Peter.
Thanks
Thank you.
very much for having us.
Fantastic. So look, before we dive into the research itself, can you tell us a little bit about LFR International, Peter?
Absolutely. So LFR was actually founded at the beginning of 2019, but is based on research that we've been conducting since 2016. We initially started in Uganda, in eastern Uganda, in a place called Iganga, where we developed a very similar system to the one that we review in the article in Chad, and worked exclusively with motorcycle taxis there to scale up a lay first responder program and follow that longitudinally. And based on the results of that study, we've continued to engage in the work and then decided to formalize an organization around the evidence base we had put together to both scale the rate at which we could implement these programs and just put all these sort of disparate projects we were working on under one roof. So it's been a really exciting project to now continue as a medical student as well.
Fantastic. Canaan, from your perspective, what drove you to pursue this line of research? What was your real sort of endeavors around this?
Yeah, so Peter and I worked together as EMTs at Washington University in St. Louis, and I'd heard about the research that he did in Iganga a few years prior at just a student organization event. And I knew that I wanted to get into teaching emergency medicine, so he and I met, and we realized that there was a big paucity of literature on rural emergency care programs in the developing world. And so I wanted to repeat his study essentially from Uganda, but in a more rural area. And so we were able to find a partner organization called Team Chad that I was able to go to Omtiman to work partner with a local physician and the local Red Cross to start to implement this program.
Brilliant. So can you tell us a bit more about the rationale for developing a lay first responder program versus, say, an EMT program or a paramedic program?
Absolutely. So obviously, in a lot of these resource limited settings, it's really difficult to put together programs that imitate or are at the same level of care as you might find in high income countries. And implementing programs like that has been tried over and over. And what people have found is that most of the time they're financially infeasible. And unfortunately, they fall apart a year or two later. And so what we set about doing is kind of looking back at the literature and seeing what else had been done and noticing that there had been a few alternative approaches endorsed by agencies like the World Health Organization. And so beginning in 2004, they began to recommend the training of lay first responders as the first step toward developing formal emergency medical services in settings in which there were no pre-existing formal pre-hospital emergency medical services. And so that was really what we've since endeavored to do more of, is add to that literature base around training lay first responders. And now what we're trying to do is demonstrate a blueprint through which one can scale a lay first responder program into a formal emergency medical services program. And that's the project we're currently working on now in Sierra Leone.
Brilliant. So there's a fantastic photo published on the slide there today, where it appears that you've sort of engaged the motorcycle taxi drivers. Can you tell us about that choice and why you went down that pathway?
Yeah, absolutely. Motorcycle taxi drivers are really prevalent across sub-Saharan Africa. They are an extremely common mode of transport, especially for short and intermediate distances. But because of the fact they're motorcycles, they're a little more dangerous than a normal four-wheeled vehicle might be. And oftentimes, they're seen as being reckless by their own communities. And so they can sometimes be stigmatized, so much so that I remember hearing in Uganda when I was there, if a motorcycle taxi was involved in an accident and showed up at the hospital and admitted to being, in that line of work, nurses might, you know, turn them away and say, listen, we know you're reckless. You caused this accident yourself. Deal with it yourself. And so they would end up lying about their profession. And so as we talked to more and more of these motorcycle taxi drivers, we found that most of them are really normal, people who just want to make a buck and aren't trying to, speed or be reckless. And that reputation is really spoiled by a few bad eggs. And so when we thought a little bit more about who we might want to train as a preliminary lay first responder program to address injury in these settings, we just kept coming back to motorcycle taxi drivers for three reasons and three real inherent advantages that they possess. The first of which is, they conduct, their profession is based on the road, and road traffic injuries and road trauma is a significant contributor to the injury burden in low resource settings and across the continent. And so training them meant that even without a dispatch system, they would witness a lot of the trauma and be able to respond quickly. Second, they possess a motorcycle, and so that it's a form of transportation that can provide pre-hospital transport. And thirdly, because they don't clump together, because otherwise that would mean they would be competing for customers, they end up self-dispersing, which provides really wide basis of coverage and geographically. So you get a much better emergency care coverage that can be adequate for communities in resource-limited environments. And so when we kept coming back to it, we said, they're the best people to train. And so we decided to do so. And what we found was these motorcycle taxi drivers were just so excited to participate because for them, it gave them a way to show other people that, they weren't all this way. And in the 1 year and 3 year qualitative follow-ups we've now done in Chad and Uganda, respectively, we found that to be consistent across both environments, that they talk about the sort of identity change happening. And so they're not just seen as motorcycle taxis anymore, but in fact, they're seen as first responders. And so as a result, the public sentiment around them changes, and communities are small enough that people will remember who is responding to these accidents, because obviously when an accident happens, hundreds of people gather around to see who's been hurt. And then out of the fray, the first responders come in and treat the victim and take them to the hospital. And so as a result, they gain a lot of public respect. And as a result of the public respect, it increases their customer acquisition. And so in follow-ups now, they're ending up making about 25% more weekly income than non-trained counterparts. And so as a result of this kind of these social and financial benefits that motorcycle taxis are accruing over time, it keeps them involved and volunteering to provide emergency medical services for free on a voluntary basis. And so, at the 3-year mark in Uganda, 75% of initial trainees were still performing. And, locally, we had used locally sourced supplies, and They knew how to find those items around their community and keep themselves equipped to continue deriving these financial and social benefits to responding. So we've just found them to be a wonderful sort of subgroup to work with and train for all those reasons.
That
And
sounds like
just to, oh, I'm sorry.
Go ahead,
Go
Tony.
ahead.
No, jump in, mate. Please
I was just
do.
gonna say to add on to that a little bit, another another thing that we found in the follow-up was that other motorcycle taxi drivers in the region had seen the impact that it had on the train or on our trainees, and so they were even I don't remember the exact statistic, but I think it was over 90% of those we interviewed said they wanted to be trained, and many of them were willing to pay for to be trained and equipped. And so they see the positive impact that being trained and being a first responder can have on their peers, and so it can really help for recruitment and long-term retention of these motorcycle taxi drivers, as well as the cost effectiveness and sustainability of it, because they're willing to pay to be trained in the future.
Absolutely. And so, along with that, what we're now investigating is doing a number of cost effectiveness studies and trying to figure out would those nominal fees contribute to sustaining these courses, and how much would one have to charge to cover all those costs to break even, to pay for trainers and a training space, and all of the supplies a responder might need to begin responding, and how can we cover that, and who can we source funding from, whether it's the local government or so on. But it's been really exciting to sort of build this evidence base, and it's been obviously a very sort of iterative development process, and things have changed as we've gone on, but it's been some really exciting results that have really supported the model we've now zeroed in upon.
Okay, so that was really interesting, and particularly how you've managed to hone in on the social and economic benefits associated with providing the program, and how that's managed to embed it. Because at the start of the podcast, you were, the first question was why you went with the lay first responders, and it seems like you've really managed to make this program stick. So fantastic, and well done to both of you. What I'd like to hear about is maybe some of the challenges that you face, because it sounds like it's been a really successful program. I imagine, and having worked in low resource environments myself, there's some significant challenges usually faced with any sort of program. What were some of those things that you guys experienced when you were trying to put this together?
Yeah, so for the project in Chad, one of the biggest challenges from the research aspect was literacy. So particularly in being able to assess how much knowledge our participants gained throughout the course. There was a knowledge improvement demonstrated on the written exams, but I didn't think that it was a complete representation of the amount of skills that they learned. And so in a lot of these particularly rural areas where literacy is definitely on a spectrum, people may say they're literate, but whether or not they'll be able to take and understand an exam, a written exam, is not set in stone. And so it's very important that we need to incorporate more verbal and physical skills assessments into the training to ensure that we're getting all of our trainees to the appropriate skill level. And then secondly, one of the other major challenges we ran into was trauma care in these areas can differ greatly from orthodox Western medicine. And so the curriculum must be grounded in evidence, of course, but in order to make the course more socially and culturally acceptable, there may be some aspects of it that need to be adapted. And there's also a lot that we can learn from even the lay people about how they've adapted emergency care and transport in these remote locations. For example, we had two of our trainees, as well as the Red Cross instructor that we worked alongside, that talked about different ways of transporting people whenever they don't have any vehicles around, and they're way out in the bush, in rural Chad, and that was very helpful thing to include in the curriculum. So it's important that you bring in these local or people who are knowledgeable about local practices already whenever you're developing your curriculum. And lastly, to continue on the cultural and the line of thinking on cultural beliefs, another issue we ran into was we taught them our motorcycle taxi drivers to always transport to the hospital. But what we didn't realize initially was how prevalent traditional bone setters were in this region. And I'm not sure how familiar you are all with traditional bone setters, but they are traditional healers who specialize in fracture care and musculoskeletal injuries. And so many of our, or some of our trainees, instead of transporting to the hospital, they would take them to be seen by these traditional bone setters. And this led to a few problems early on in the progression of the program.
Thanks, Canaan. That's some really useful insights. That there's many people who read PDM magazine and look through that literature that are engaged in humanitarian practice, and it's really important to share lessons learned for practitioners out in the field. So thanks for sharing some of those insights with us. You've highlighted some of the structure and the direction that you took with this. I see that you've used trailers with motorcycles, and you identified before that the majority or a large proportion of the cases that you're attending are related to trauma. Can you tell us how effective or useful that model of care has been in terms of transportation of patients?
Yes, we were very excited whenever our local partners started developing this trailer. This trailer ambulance that can be attached to motorcycles that you see in the picture here. So the biggest advantage to using this style of transport, particularly with the trailer, is that throughout the Sahel region, there's a 3 to 4 month rainy season that comes every year from approximately, depending on where you're at, approximately June, July through October, November. And during that time, rural areas are almost completely blocked off due to flooded roads. But motorcycles are usually able to navigate through a lot of these flooded roads better than four-wheeled vehicles can. But before before we developed these trailers, there was no real way to transport very ill patients, very injured patients, particularly if they have multi-system trauma or spinal trauma, from these rural areas to get to the local hospital in Omtiman. And now with these trailers, they're able to navigate through all these flooded areas to get there, which presents an opportunity both for it's an amazing opportunity for emergency care, but also to maintain rural communities' access to, chronic care even during the rainy season. And so far, the motorcycles for lesser trauma, so not multi-system or spinal trauma, they've been very effective even with motorcycles alone in being able to transport patients because they can fit a third responder a second responder behind the patient, with the patient sandwiched in between the driver and the second responder. And so that's been very effective as well.
Yeah, so that was actually a model we began to create with local partner input back in Uganda, since tested in Chad and now rolled out on a larger scale in Sierra Leone. Again, sort of including local partners at each stage of development. And what we've since come up with is a list of 3 contraindications that helps determine when someone can and cannot be transported by motorcycle. And as Canaan mentioned, that means someone who is put onto the back of a motorcycle with a responder behind them. So you end up with 3 people on the motorcycle, and all of these is motorcycle taxis. They have an extended seat, so you can fit, up to 3, 4 people fairly comfortably. But the 3 sort of indications for when one cannot transport a patient and has to wait for either a flatbed truck or a Toyota Land Cruiser or some other vehicle with the capability of transporting someone in a horizontal fashion, or the indications in which you cannot take them by motorcycle are if the patient has a double lower extremity fractures, if they have pelvic instability or pelvic fracture, or if at any point during the emergency incident the patient has been unconscious. Other than that, we found that obviously the benefits to transportation outweigh a lot of the other indications, and that you can do it safely if they have an extremity fracture or anything of that nature. And so in Sierra Leone, we've trained 4,500 responders now for a place called Bambali District. And we have an article submitted to Injury at the moment. But we had 1,850 patients over 6 months, and 93% of the time they were transported by motorcycle, reducing the need for traditional box ambulances or ambulances you might see in high-income settings that oftentimes a patient's sitting upright or just, in the back of the truck, and it's a huge financial burden and really cost prohibitive in those settings. And now patients who otherwise wouldn't have received transport or would have had to walk to a hospital can hop on the back of a motorcycle and be brought in a safe manner. And so it's something we're continuing to iterate upon and really monitor closely. But we found it to be a really easy way to expand access to emergency care. And oftentimes, rapid transport is such an important point, especially if someone's hemorrhaging or things like that. And so getting them there is essential. And so we found it to be a way in which we can expand both access to emergency care and definitive care at hospitals in the clinical setting, but also just get, minorly injured people to definitive care as well, quickly.
So it's great to hear that the success of this program continues to grow. What's your plans for the future for the pair of you? I understand you're both at medical school at the moment. What's your future vision for the lay first responder program?
So something we're working on at the moment actually is submitting there's an R21, R33 grant proposal out at the moment that we're going to be submitting a grant application for. And that's just a National Institutes of Health funding mechanism for international research. And so what we're hoping to do is begin to study the application of dispatch systems to lay first responder programs and training lay first responders. So, as lay first responders and training lay first responders is recognized as the first step toward formal emergency medical services development. Then being able to notify and provide targeted care and dispatch the people you've trained is also recognized as one of the next steps to formalize that program. And so what we're hoping to do is raise funding to be able to implement what's called the Beacon Emergency Dispatch System, which was developed by an organization with support from the World Bank since 2015. And I think they also got support from USAID as well. But that was started by a guy called Jason Friesen, who's a former paramedic and now works on this full-time. But we're hoping to be able to apply that to our program on a large scale in Sierra Leone and begin to study response times and the way that changes emergency care coverage and the proportion of patients receiving care, and then externally validate that in some of our other project locations. But what I think we're really hoping to do over the next 5 to 10 years would be formalize a blueprint through which one can take a setting that has no formal pre-hospital emergency care and then bring it to a point at which it's providing a similar level of care to that which you might expect in a high-income country, but do so in a really affordable and cost-effective manner, using alternative systems that we found to be effective.
That sounds like a fantastic mission, Peter. Look, I wish you both all the success in the world. Thank you so much for joining us here for this podcast, and thank you both for taking the time to publish with Pre-Hospital and Disaster Medicine. For those listening, the link is there to read the article and the research that Peter and Canaan have developed. Warmly recommend that for those who are engaged in this field and want to learn more about what they've managed to achieve so far. Thank you both for taking the time to speak with us today.
Thank you so much for having us again, making the time.
Yes. Thank you. Thank you so much for having us today.
Okay, take care everyone out there, and thanks for dialing into the Pre-Hospital and Disaster Medicine podcast.